Hello, my name is Chantal Roy, and today we are going to be going over how Firocoxib is a highly effective treatment in equine colic cases. The main points that we're going to be going over today include colic, the inflammatory response, and how COX inhibitors aid in Firocoxib treatments in colic cases. 30% of horse deaths annually are associated with colic. This is in comparison to horses that die of old age as well as in kill pins. Any horse can have a colic event, therefore it's not dependent on age, breed, or association. There's no prevention or treatment of colic, and we can only treat the side effects of a colic event. Therefore, it is imperative that we use scientific technologies and advancements in order to find proper treatments for colic events. NSAIDs are the only type of treatment that we have for colic events. NSAIDs stand for non-steroidal anti-inflammatory drugs that alleviate pain as well as reduce the inflammatory response within the horse. Prostaglandins and COX enzymes have also been heavily studied in order to be a target for the NSAIDs. Colic is associated with any type of abdominal pain, therefore there's a plethora of different causations and types of colic. Horses can eat too much sand and have a sand embolism, or they can eat a stick and perforate the bowel further. A little more serious, we have impactions here. You can see how roundworms have been integrated into the small intestine. They cause an impaction of not only themselves as well as other digestive materials, and then cause the intestinal lining to rupture. Further, you can also have a gut twist within the small intestine. The small intestine is made up of three main sections, which include the duodenum, jejunum, and the ileum. The jejunum has a very long mesentery, therefore it's able to float around within the abdominal cavity almost freely. Therefore, gut looping and gut twisting is highly variable within the horse. As you can see here, this gut has been twisted and therefore has allowed for necrosis to occur due to the lack of blood supply happening. Veterinary assistance will have to occur for both of these situations and most likely end with surgical colic. Surgical colic is when a exploratory laparotomy occurs and they take out their entire gastrointestinal tract in order to explore it, in order to find where that colic event is occurring. With this, it's extremely invasive and therefore causes a lot of intestinal damage. Colic can cause necrosis as well as perforated bowel. However, surgical colic can also increase the bacterial exposure beyond the bowel being perforated. Further, endotoxemia is one of the most deadly types of bacterial exposure. Endotoxemia is when bacteria is being degraded by something such as a phagocyte, and then the parts of that cell from the bacteria are then broken up into things, cellular components. The most deadly endotoxin is considered to be a lipopolysaccharide from the bacteria. It makes its way through the basement membrane and into the blood vessel of the horse, and then the immune system and inflammatory responses are overexpressed, leading to sepsis and death in the horse. The inflammatory response is associated with the injured tissue from the colic event, and that releases the phospholase A2 and the retinoic acid. From the retinoic acid, COX-1 and COX-2 are produced and then allow for prostaglandin production. Right here, during the inflammatory response, we have a pivotal point between COX-1 and COX-2. So COX-1 is associated with your homeostasis functions. They are constitutive, therefore they're on within the body at all times. COX-1 produces thromboxane A2, which deals with your platelet aggregation and allows for blood clots to form. Your COX-1 also deals with prostacyclin PGI2, which deals with your intestinal mucosa being formed, therefore it's downregulating the hydrochloric acid from the stomach coming in with the digestive system, allowing for the upregulation of mucus protection for that microvilli and villi within the small intestine. COX-1 is also associated with the prostaglandin E2 and is dealing with your renal vasodilation and upregulates your sodium and water excretion. COX-2 is also associated with your inflammatory stimulus. It has to be induced, example from your from your colic event. COX-2 increases your inflammatory mediators, such as your macrophages that we talked about earlier with endotoxemia, as well as your cytokines. Your cytokines are signaled and then trigger a cascade of signals for your immune system to be triggered. COX-2 also produces prostaglandin E2, which deals with your renal vasodilation, and overall, COX-2 is associated with inflammation, redness, swelling, pain, and overall triggering of your immune system. Looking at here, your NSAIDs use both COX-1 and COX-2 as inhibitors in order to adjust as anti-inflammatories. There are two different types, which include non-selective and COX-2 selective. Non-selective both inhibit COX-1 and COX-2. The advantages of inhibiting COX-1 and COX-2 are obviously the anti-inflammatory effects of inhibiting COX-2, as well as interfering that platelet aggregation that occurs within COX-1. Some disadvantages of this is that the GI tract is then suppressed for positive prostaglandin production, and it also increases that hydrochloric acid coming in from the stomach, and therefore decreasing that gastric protection within the small intestine. Further, it induces vasoconstriction within the renal system and increases that blood pressure seen, as well as increasing cardiovascular complications due to that increased blood pressure seen within the kidneys. Looking over here at COX-2 selective NSAIDs, they have the advantages of also being anti-inflammatory. However, they're also COX-1 sparing. Therefore, they are able to spare those homeostasis functions of COX-1 and not allow for those adverse effects to occur. Some disadvantages we see here are your cardiovascular complications. For example, you now have a lack of that platelet aggregation due to the retention of the COX-1 functions. However, you also have the disadvantage of your renal cytoprotection being decreased due to that enhanced platelet aggregation from your COX-1. Firocoxib is seen as an upper due to the fact that it's highly selective as a COX-2 inhibitor. It is COX-1 sparing and is 265 times more selective at inhibiting COX-2 rather than COX-1. Nothing is 100%, but it's highly effective in only inhibiting COX-2. Firocoxib is available in two different types, known as an oral paste as Equinox, as well as in a tablet as Privocox. And one of the preliminary investigations done by Barton and colleagues, they looked at the effects of both of these types of firocoxib within horses, and they saw that prostaglandin E2 was reduced in both the canine chewable tablet Privocox as well as in the equine paste Equinox after 7 days after the first administration. Dosages of firocoxib include 0.1 milligrams per kilograms daily. Firocoxib pharmacokinetics. Some important aspects here, we have the half-life of 30 to 40 hours, which is substantially higher than any other NSAID on the market today. Further, it is also detectable after 4 hours and stays in the system after 7 days after administration. A study done by Ortriv was the one to discover this in order to look at plasma concentrations of firocoxib within the horse. Once again, it was detectable first at 4 hours and then up in the system until 7 days. They did this in order to look at horses in order to find a test to allow for the induction of competitive horses back into the field after being given an anti-inflammatory such as firocoxib. Firocoxib was also compared to the common NSAIDs on the market. Excuse me. Flexin is a non-selective NSAID that inhibits both COX-1 and COX-2. It is commonly known as Banamine in the field and is primarily used both post and preoperatively for colic. Phenylbutazone is the second one. It's moderately selective and it's commonly known as Bute and is used for pain alleviation post-operatively most often. And the important sections I want you to look at here is that the half-life and detectability of both of these NSAIDs are substantially lower than firocoxib. Therefore, you have to re-administer both of these drugs a lot more than you have to do for firocoxib. In a study done by Ziegler and colleagues, we looked at the platelet aggregation due to thromboxane 2 production. As you can see here, firocoxib is in the red and Flexin is in the blue. Firocoxib showed a lot higher levels of platelet aggregation in comparison to Flexin. They also looked at pain scores between Flexin and Meligum treated horses. After 24 hours, Flexin had much higher pain scores in relation to firocoxib treated horses. The pain scores were determined upon behavioral as well as heart rate ratios. Firocoxib was also looked at in relation to the intestinal mucosa protection. In A, we have a healthy horse with no NSAID or colic events. You can see the microvilli is greatly populated along the sides of the villi, allowing for proper nutrient absorption. However, here in B, you have a horse that was treated with Firocoxib after a colic event. As you can see, the microvilli are still populated along the sides of it, and there's still marginal length within the villi. In letter C, we have a horse that was treated with urflexin. As you can see here, the microvilli are starting to degrade, as well as sloughage of the villi. Here in figure E, we also have a horse that was treated with phenylbutazone. As you can see, once again, you have that degradation of your microvilli as well as shortened villi overall. Platelet aggregation was also looked at within a different study by Burkett and colleagues. Platelet aggregation once again showed that Firocoxib had little to no inhibition of the platelet aggregation in comparison to flexin and phenylbutazone. However, one special thing about this study showed that both phenylbutazone and flexin had a implication showing that they had a precursor for SCD14. SCD14 is a biomarker for endotoxemia. Therefore, horses that were treated with phenylbutazone as well as flexin both had an increased chance of getting a reentrance of endotoxemia after being treated for colic implications. Some further research that will have to be noted. At the end of the day, COX-2 is not just within your gastrointestinal tract, it is throughout your entire body. Therefore, it is mostly concentrated within your CNS as well, along with used in some mechanisms of cancer. Therefore, we need to be looking at how the use of Firocoxib is affecting and possibly increasing the risk of neurodegeneration, as well as increasing the potential risk of colon cancer. Another aspect that we need to be looking at after prolonged use of Firocoxib is the decreased sodium retention in relation to the maintained PGI2 production, as well as the prostaglandin E2 production decrease from the COX-2 inhibition, and to see if there could be a potential increase in blood pressure and overall cardiovascular issues. In conclusion, we have looked at the different types of colic and the association that they have together, along with the inflammatory response that occurs after a colic event. Overall, Firocoxib shows a promising treatment in horses that have experienced a colic event. Overall, you see an stable platelet aggregation after the use of Firocoxib, as well as mucosal protection, and no biomarker of endotoxemia. Further, it stays within the horse's system for longer, therefore no need for less, there is not a need for more administration than necessary. The importance of this is that horses can't talk. At the end of the day, we have domesticated them, therefore we are responsible for them. As researchers and veterinarians, we are responsible for not only their recovery, but also their overall health. Therefore, we cannot prevent or know when a colic event is going to occur. However, our response time is imperative. Do we have any questions? Here are my references. Thanks and have a great day.